Hello, everyone. Thank you for joining us today. For those whom we haven't met, I am Sabrina Shum, the head nurse for the Hospitalist Medicine program. And with me is Amanda Stewart. She's the iPace mentor for the Hospitalist Medicine program as well. Today's presentation is about the iPace pilot project that was initiated in January. However, it was interrupted for a couple of months because of COVID, but we recently received the green light to resume the project again. Today, we will be reviewing phase 1 and discussing what this project means for you, and also providing an update on phase 2. Let's begin by reviewing.
So as we know, people are living longer with multiple comorbidities and higher levels of frailty. In fact, by 2025, only 20% of Canadians will die with an illness that has a recognizable terminal phase. These less predictable trajectories make it more difficult to share prognosis, which we know is essential for informed decision-making, but also mean it's increasingly difficult to recognize the need for a goals of care discussion prior to a crisis or decline. This leads to conversations occurring late in the patient's illness and limiting its impact on care. This is highlighted beautifully by the bow tie model of palliative care. So as we know, palliative care is holistic person and family-centered care available for people living with any illness at any age and at any stage of a life-limiting illness. This complex pain and symptom management focuses on improving quality of life, reducing suffering, and promoting understanding of illness. We want to highlight that palliative care works best when it's integrated early and alongside active treatment. When utilized this way, it is proven to help people live better, but also live longer. Goals of care defined. Often when we hear goals of care, I think it's easy for healthcare providers to think about the most form or the code status. But just as important as the medical decision made is the reason behind that decision. And goals of care all encompassed is also about exploring patients' medical, but also non-medical priorities and values. So for example, a patient is adamant on remaining at a high level of intervention when this seems inappropriate to us, but it's because the patient wants every chance possible to meet their granddaughter who's due next month. This slide is really to clarify the different intentions between the advanced care plan and goals of care record and the most. So the most is medical orders that utilize standardized language and broadly or generally categorize the level of medical intervention chosen. So we know that every M3 isn't necessarily going to pursue the same interventions as another. And it's through the goals of care discussions that the care team explores the range of treatments available and sort of selects the ones that align with the patient's wishes and values. Documenting these conversations on the advanced care plan and goals of care record will enhance communication and understanding of the patient's medical decisions selected on the most, as well as the ongoing care planning taking place.
As I mentioned earlier, this project was initially started in January, and it was identified as a high priority target for quality improvement. This project is particularly relevant for the population that we serve, as a large number of our patients have very advanced chronic disease and life-limiting illnesses. Historically, goals of care conversations were perceived to be a physician responsibility only. But in this project, our goal is to have everyone participate in having goals of care conversations. Nurses, OTs, PTs, social work, they all bring their own lens and build rapport and engage in conversations with patients. And it makes sense to take a multidisciplinary approach. And we are achieving this by having each discipline integrate a few questions from the Serious Illness Conversation Guide into their admission workflow, but also throughout the patient's hospitalization, and to document them in a unified location so that the information is easily accessible and can be shared with the whole team. We are also here to support and mentor all staff in engaging in these discussions and to increase their competence and confidence. You will see here a very nice long list of all the positive impacts of having early conversations. You will see that many of them are for patients and families, such as better quality of life for the patient, family feeling less burdened with medical decisions, but also early conversations help us decrease moral distress associated with futile interventions or undue harm, and decrease clinician burnout. Now we will walk you through an admission example.
So those that have had iPace training or saw our presentation in the new year will be familiar with the Serious Illness Conversation Guide that VGH uses to structure goals of care conversations. You may find that you already ask similar questions on admission and when doing the MOST form, and likely explore some of those key topics on the left in your day-to-day work. Like Sabrina had said, we've been working hard to engage all members of the interdisciplinary team to get involved and participate when this information is offered up to them due to their clinical expertise or personal rapport with the patients and families. Hopefully most of you are familiar with this form by now. This is the Advanced Care Plan and Goals of Care record. It lives right behind the MOST green sleeve in the chart. This picture shows the tab that we have attached based on your feedback from our first presentation, and we have now attached those to the Hospitalist admission PPOs, which you had also asked for. So you'll see the additional section on the Advanced Care Plan for the screening tools, which I'll show you next. We wanted to let you know that this form is a legal document and should be accompanied with the MOST. And by the end of this project, the hope is that this will be the one-stop shop for advanced care planning and goals of care information. Because we've integrated a multidisciplinary approach, you'll see on the tab we've laid out the possible questions we thought would be most impactful from the physician point of view from the Serious Illness Conversation Guide, as well as the surprise question being an important screening tool when it comes from the physician perspective. So these are the 3 screening tools that go along with the Advanced Care Plan and Goals of Care record. Number 1 is the frailty scale, and this one is to be completed by OTPT. It's a really great example of a patient's overall function and well-being. Number 2 is the SPICT tool, and this wasn't assigned to a discipline because it can be quite lengthy and it's quite in-depth and it doesn't always apply. So it's a little bit more patient-specific, but is a good one for those patients that we might feel are more appropriate or sort of transitioning to supportive and palliative care. And then number 3 is the surprise question, which we have assigned to physicians. It highlights that although not all of our patients are necessarily nearing the end of life stage, they are all facing a life-limiting illness and are potentially in that unpredictable stage we had talked about earlier. So in the short few months before COVID, there was a lot of success in the practice change. So as you can see, our strongest week for the goals of care information being documented on the Advanced Care Plan was 50%, which is a huge improvement from 0, and that was just in the first 48 hours alone. As well, 8 different disciplines charted on the Advanced Care Plan, which is amazing. It's not that everybody wasn't already engaging in goals of care conversations, and they were likely gathering this information prior to the project. It's just that now there's improved documentation, and it's in a unified location that is easily accessible for all. And we did do a post survey in June that reflects that we are meeting our aim, as 86% of respondents reported an increase in their competence and confidence engaging with patients and families in regards to goals of care conversations. Here are a couple physician entries on the Advanced Care Plan that we pulled up to show you. 2 of them are really great examples of exploring underlying priorities and values, and are really good examples of documenting the goals of care conversation that led to a code status decision. So everybody understands what was talked about and where we're sort of starting in regards to goals of care. The top left example is just to highlight a great physician entry, but also that this physician completed all 3 of the screening tools, which is great. And so that would highlight to me, or hopefully to other members of the team, that this physician felt this patient was at quite a high risk and identified a lot of risk factors for complicated goals of care or family dynamics, and just really needing to be engaged in goals of care conversations as early as possible. And then the bottom right is a great sort of case to highlight about the importance of having these conversations early. This question was asked during intake, and the substitute decision maker was identified while the patient was clear and able to speak for themselves. That patient did decline quite quickly, and the team was able to rely on the substitute decision maker to help plan care, which we wouldn't have been able to do necessarily if we hadn't had highlighted who the substitute decision maker was going to be before the patient lost their ability to speak for themselves. We also wanted to highlight some multidisciplinary entries. So we think that the advanced care plan is a great communication tool, and we'll talk a little bit about that later, but this is just to show that if we sort of all come to the table with our own expertise and rapport, like we've been saying, and so if each of us contribute a piece of the puzzle, we come together to paint the full picture of goals of care for this patient. So if we start at admission and contribute throughout the patient's stay, these conversations can really be the compass to guide the care that we're providing.
So what's next in phase 2? In phase 2, the asks of the care team remain the same. Every discipline is to continue to integrate goals of care or serious illness conversation guide questions into their admission workflow, and also continue to recognize valuable goals of care information that arises in their day-to-day practice or interactions with the patients, and to document them in on the advanced care plan goals of care record. And they will also continue to use to participate in the use of screening tools. So what's different about phase 2? Although we have been successful in helping staff to adopt a practice change, a shift in culture is also necessary to elevate the practice change to influence patient care in a greater and more meaningful way. And so the approach that we will be taking moving forward is to help staff connect the dots and use the information that they have gathered to its fullest potential and see how impactful this work can be on patient care. You will now see on the screen a process map that outlines the processes of a patient admission. The salmon color boxes represent the care team, while the yellow process is representing Amanda and I. So like Amanda said earlier, at our most successful week, 50% of new admissions had documentation on the advanced care planning goals of care record, but it still meant that it didn't happen for 50% of them. So this new process that we've added is really to ensure that none of the higher risk patients, the ones who we really feel need to have goals of care addressed sooner rather than later, none of those patients fall through the cracks. I often like to describe this process as this yellow added process as the training wheels, and it really is meant to support the care team while the process is solidified and everybody is able to ingrain this work into their practice, and so that once this project ends, the team can carry on without our support. So you will see in the diamond, which is the first step that Amanda and I will be doing, is a chart review of every new admission that comes on all 4 hospitalist units at VGH within 48 hours of admission. And this chart review will include bringing information related to goals of care that has taken place in the community. So any goals of care discussions that have happened in the community and that are documented, we will be bringing that to the team so that we know where to start. And this chart review process will really help us identify any red flags and help us know what we have to work with. our next step will be to meet the patients ourselves and to sort of perform a readiness assessment for to engage in conversation and to start building rapport. And then we will work alongside the team to address any issues or gaps in carrying out goals of care conversation and really help with developing a plan that truly honors the patient's goals and values and beliefs. And our last step is on discharge. We will, what we hope to do is to have all that hard work that we put in having the conversations, all of that would follow the patient into community wherever their destination is. If it's at home, then we would make sure that the GP gets a copy of all of the discussions that we've had, or their long-term care facility or their community health team. And you will see that for patients that are lower risk, so those are the uncomplicated patients, the ones who have clear and documented goals of care, we will not be following them from the get-go. However, if they become complicated at any given moment, there is always the opportunity to refer to Amanda and I, and we can help support the team in resolving or overcoming some of the barriers. So again, some of our roles and responsibilities include prioritizing the patients and families that are at higher risk of conflict or complications around goals of care or healthcare expectations. One of our main focus is also education. So we educate staff about the palliative philosophy and approach to care, but we also want to educate patients and families in, we're really hoping to normalize these conversations so that every time they come to the hospital, it's something that they can expect and don't feel like it is sort of awkward to talk about. And again, we work collaboratively alongside all members of the multidisciplinary team to address any issues regarding to goals of care discussions. And all this work that we do is really to promote patient-centered care through informed and collaborative decision-making. We also hope to be able to engage patients and families in future care planning that go beyond the current hospitalization. To summarize, the advanced care planning and goals of care record is really a communication tool that enhances the understanding of the patient's wishes for all members of the care team. If we use this document effectively, it helps us avoid repetition of time-consuming conversations. And also during handover, for example, it helps us provide a deeper understanding or insight into the conversations and all the hard work that we put in for the oncoming physician. It helps us avoid having to start over and instead can help us move the discussion forward. Sometimes it can be really helpful in identifying the potential triggers, and once we're armed with that knowledge, then it helps us avoid those triggers in conversation. And really it helps us save a lot of time when we're not having to dig through different sections of the chart or searching for previous documentation in old charts if all the information is readily accessible in one unified location. And just like in phase 1, to measure our progress, we will continue to do chart audits to track participation and identify any gaps, and that helps us know where we need to put in more support or education. There will also be ongoing data reporting that we will be receiving from decision support in relation to some of the secondary outcomes that we are hoping to achieve, such as a decrease in patient complaints, a decrease in length of stay, readmission rates, and hopefully more referral to community services. We also look for any subjective feedback, so any success stories or quotes from staff or patients and families. Thank you very much for listening. Have a good day.